So we'll flip over. We're going to talk about ultrasound, a subset of ultrasound in the scrotum. And this is probably one of the most important subsets other than torsion. And this is what to do when you find a bump in the scrotum on your scrotal exam. There we go. I have no relevant disclosures, but I was lecturing in New Zealand a few years ago, and we were driving into this town, and I loved the sign, and it said, "Be a good driver. We've got a couple graveyards, and we don't have a hospital." Thought that kind of sent it pretty well. So this talk is going to be liberally illustrated from my journal of choice, Sports Illustrated. You can see the structure of the talk, introduction, intratesticular, extra-testicular there. This is the very first ultrasound ever published by Fred Sample. It's bistable, black and white. He was showing a hematocele, and you think how blessed we are with the hardware and the software that the manufacturers are giving us now, and we can see unbelievable things. One minor point here, please in your reports always address the mass. We get a lot of complaints from our referring docs where they come in, the patient palpates a mass, and we say it's a normal ultrasound, and they want something from us that we palpated the mass, the patient palpated the mass, we put the probe there, we looked where everybody felt the bump, and it turned out to be an epididymal cyst. So just address the mass in your reports. Obviously, one of the most important issues we face is tumor. You know, look at Lance Armstrong, John Kruk, the list goes on and on right there. And in general, remember that a mass in the testicle is malignant until proven otherwise. There are exceptions to this, but I've seen several legal cases over the years where the radiologist got too cute, listed 10 things in their differential and sarcoid and TB and this and that, and you're talking to a nurse practitioner or a PA and tumor's number 3 on your differential, so bad mistakes were made. So if you don't know, a mass in the testicle is malignant till proven otherwise, if you have questions, send it to somebody that does a lot of ultrasound or has a uro-onc involved. So this is the most common solid neoplasm in males in the 15 to 34-year-old age group. About 95% are germ cell tumors. A little over 50% are mixed germ cell tumors, a little under 50% are seminomas. Just like Richard was talking about with RFI, we cannot distinguish benign from malignant, in this case using color Doppler. Non-specific appearance. Lee Melson wrote a paper years ago talking about a 50% false positive rate, getting tripped up by infarcts or hematomas or abscesses. I think as our collective knowledge has improved and we've gotten better and better machines, we're really good. But again, in a few exceptions, masses in the testicle are malignant until proven otherwise. And this is just an example of kind of an unusual Leydig cell tumor there. Here are two classic seminomas. We've all seen these a million times in our practice. The bottom image came in for rule out torsion for pain. So remember that a big chunk of testicular tumors hurt. In medical school, we were taught that they were painless masses, but they infarct or they bleed. So when somebody comes in with pain, always worry about an underlying tumor. And not all focal bumps are seminomas. Here's a rare case of a melanoma metastatic to the testicle. Doesn't happen that often, but you can see the PET scan here. So just everything is clinical context. This was a really nice guy, a farmer who had noticed a slowly growing scrotal mass, but he was very stoic. He wanted to bring his crops in, so he came in, delayed diagnosis. Look at the size of this seminoma here, how vascular it is. But again, if you had to pick a tumor to get, this is the one to pick. He had orchiectomy, no nodes. He was doing great 5 years later. So this is a good tumor to pick here. And nonspecific appearance. Here's another seminoma taking over the entire testicle. You can see the mediastinum testis in the middle. And to my eye, it looks very similar to this case. Here's the mediastinum testis, seminoma, lymphoma. Here's another patient with testicular lymphoma, large mass on the right, small mass on the left. We didn't biopsy the testicle because he had a big bump supraclavicular, so we biopsied that. They gave chemotherapy. The left completely melted away. This stayed for years, and so presumably this was just fibrosis and scarring and not any other tumor. But look at this, testicular lymphoma is a rare malignancy, but it's the most common testicular neoplasm in guys over the age of 50. So I always thought it was really rare, but look at all the data you have if a 70-year-old comes in, particularly if they give you a history of lymphoma or leukemia, because it's hard for the chemotherapy to get inside the testicles, so that's the #1 spot for recurrence right there. They're often very, very vascular. Look at this pretty image Mike gave us. So in another setting, if this guy was a sailor on shore leave and had fever and discharge and all that, you'd say this is an epididymitis. But the beauty of ultrasound is you get to talk to the patient, and when he gives you no leading infectious histories but says, yeah, I finished my chemotherapy 6 weeks ago, you're going to worry about lymphoma. This is leukemia. I love this case given to me by Bill. This is the first color Doppler ultrasound unit out there, the quantum unit, and it looks like a little bit like an Atari video game with these blocky kind of vessels there. But the patterns of lymphoma and leukemia, they can be cannonballs, in which case you're going to suggest it, or it can be a diffusely enlarged hypoechoic, hyperemic testicle, and the differential is history of STD going down that pathway versus, doc, I finished my chemotherapy 6 weeks ago. So always think of lymphoma and leukemia when you get these hyperemic testicles like that. So when Paula was at AFIP, she nicely showed, unifocal, multifocal, and seminoma taking over the entire testicle. The other common one we see is mixed germ cell tumor. It's a little bit more common. We're really, really good at making the diagnosis because of the cysts and the calcifications. We pat ourselves on the shoulder, but in reality, the urologists don't care because it's a bump in the testicle and it's coming out there. So mixed germ cell tumor, #2, lots of cysts, very heterogeneous. This kid was playing hoops, got hit in the groin. Here's the mixed germ cell tumor that ruptured. Here's the hematoma. Here's the hematocele. So again, always look for an underlying tumor in the setting of trauma. We get some interesting sports out in Utah. So there's something called base jumping, where they jump off of buildings or bridges with a parachute. And this guy's parachute strap kind of caught him in the balls there. And it was a good thing that he came in because we diagnosed his mixed germ cell tumor following jumping off some cliff somewhere. Another case, mixed germ cell tumor, pretty easy thing to diagnose. I put this in to remind us that embryologically the testicles start in the upper abdomen and they migrate caudally with embryogenesis. So their venous supply, their arterial supply, and their lymphatic supply is all up by the renal hilum. So always look for nodes not in the pelvis, but up by the renal hilum, and you can see one developing here. Another case who had a classic mixed germ cell tumor in the testicle. We go ahead and look, and we live in America, we're blessed, so everybody's getting a CT scan, but we like to get a jump on it. So if we diagnose a testicular tumor, we take a quick look, we don't charge for it. And massive mass causing hydronephrosis. Here's the mass up here. Look at the poor renal artery just completely bracketed by masses there. Here's the spine, the aorta, lots of masses. So adenopathy with testicular tumors is upper abdomen, not down in the pelvis. And this is a classic mixed germ cell tumor. So now let's move to some of the more interesting things. Buzzword here is lamellated onion skin appearance. When you see this, you're going to be right 99.9% of the time. And this is an epidermoid inclusion cyst. I got this one from Jason. These are benign, but in general, the patient and the urologist are uncomfortable with the bump in the testicle. The value we add is we say we're almost 100% sure this is benign, so let's go do a enucleation and save the testicle as opposed to the urology knee-jerk reaction of radical orchiectomy. Here's another one from Mary, lamellated onion skin appearance. Here's another one. This is our path correlate, different patient, but you get the idea of that lamellated onion skin appearance, epidermoid inclusion cyst. These are benign. When they get bigger, they can look a little bit funkier, but again, this just doesn't look like a mixed germ cell tumor or a seminoma there. This is a more recent one where you have these little cholesterol deposits that kind of ring down coming in. This was totally inside the testicle at orchiectomy there. Notice the little cyst of the tunica albuginea going by, true and unrelated. Learn from our many mistakes. We called this a mixed germ cell tumor because it was weird looking. But in reality, look at the cine clip there, and you see this lamellated onion skin appearance up here. The urologist tried to make us feel better and said, we were going to have to take it out, the whole testicle out anyways because it's so big. But again, learn from our mistake. This is not a mixed germ cell tumor. This is just a huge lamellated epidermoid inclusion cyst. Changing venues, we have 3 or 4 bumps in the testicle bilaterally. They're not abscesses because they have blood flow in them right there. This is a Caucasian, turned out to be sarcoidosis. We totally blew this case, because we didn't have the leading clinical history there. But I give this talk in Southeast Asia and people just yawn and say, it's another case of TB. So granulomatous disease, whether tuberculosis or sarcoid, can give you multiple bumps in the testicle. The next 2 or 3 cases were a lot more classic because they were African Americans being referred to us from ophthalmology clinic or pulmonary clinic there, so we had a little bit of a lead-in, but you can see bilateral testicular masses. Again, you can strongly suggest the diagnosis of sarcoidosis in that clinical milieu, but people tend to get nervous when there's bumps in the testicles, so it's good for us because they generally go to path biopsy proof. Here's another one where the primary mass is up in the epididymis there, but we still do have bumps inside the testicle, and this is another case of sarcoidosis. We'll see this about every 2 or 3 years. Your heart drops. This kid came in for rule out torsion, but he's sitting there chewing gum, talking to his mom. This is not a torsion right there, but he has bilateral testicular masses, and we're like, is this bilateral seminoma? Is this lymphoma? You're thinking it's something horrible, but it turned out to be bilateral adrenal rests in congenital adrenal hyperplasia. Remember the embryology where the testicles start in the abdomen and migrate caudally. 10% of us in this room, both guys and gals, have little bits of adrenal tissue inside our testicles. For 99.999% of us, it doesn't matter. But if you have congenital adrenal hyperplasia, that enzymatic deficiency, your hypothalamus says, hey, I don't have enough adrenal hormones floating around in the blood, and it sends out a chemical messenger to the whole body saying, if you're adrenal tissue, I don't care where you are, bulk up and work harder. So if you're the 1 in 10 guys who has adrenal tissue in your testicle, that bulks up and gets bigger, and there are horrible case reports out there where these patients have received bilateral orchiectomies, and all they needed was exogenous steroids. Now, this is one of the things we test for when your kids are born when they do a heel stick. So most of the time the patient knows about it, but a lot of the mid-levels, a lot of the family docs don't know about this entity. So always think of adrenal rests in the setting of congenital adrenal hyperplasia. I'll always remember this case, young kid, just gotten married, came in coughing up blood, went to his outside docs, cannonballs in the lungs. They did a beautiful transhepatic biopsy of this renal mass. It came back renal cell carcinoma. They told him you have about a 1% 5-year survival. Go down to the university, they'll give you some poison, maybe we can bump into 3%. Fortunately, he got the medical student who did the typical 2,000-page history and physical. And as part of that, they palpated a bump. I'll always remember this. This was Christmas Eve, about 7:30 at night. The chairman of urology was on call. He's standing behind me as I'm scanning the patient with his young wife in the room. I whisper to Paul what this is, and Paul turns to the patient and his wife and says, "Congratulations, Mr. Smith. You have widely metastatic testicular cancer." Doesn't sound all that good, but it turns out his 5-year survival just went from 1% to 90+% up there. So anytime you have a young kid with lots of horrible stuff, say, have you done a physical exam? Should we do a scrotal ultrasound? And remember that path isn't perfect. This was read as a renal cell carcinoma, and when we went back to the pathologist, they said, hey, you told us it was a renal mass. Instead, this is the adenopathy just pushing into the renal hilum, and they said under the microscope, the two of them looked the same. So again, it's clinical context bringing everything together. Cystic testicular lesions. This is from Tour de France, so I thought it was appropriate for a GU talk. There's a bunch of cystic things that you can see in the testicle. I called this one a mixed germ cell tumor. I'm going to call it a mixed germ cell tumor the next 2,000 times I see it. It's got cyst, it's got solid, it's got calcification. Turned out to be a diabetic with an infarct, so there's a differential for everything. This is an ant mini. If you see this, we're done. This is a cyst of the tunica albuginea. The only funky thing about this is that they palpate hard. So patients are worried that they've got a hard mass in their scrotum there. And so for whatever reason, this is just a balloon under a lot of pressure there. But once you see this, you're done. They're often multiple. You can see a couple of them up here. Sometimes they've got crud in them. Ted sent me this one, blood or protein. But the location, they feel hard. There's no vascularity in them, no further follow-up. True intratesticular cysts are quite rare. This is one of the only ones I've ever seen. We followed him for about 5 years until he got bored and quit coming back, and it turned, it was benign for that whole time. But if you read our chapter in Rumac, you see that people say, well, just like dermoids, mixed germ cell tumors or dermoids in the female can be predominantly cystic. Shane sent me this one, totally cystic on their initial image, looked gorgeous, and then 6 months later, there's a bump there. And here's the path thing. So this turned out to be a germ cell tumor. So in the rare instances when you get a true intratesticular lesion, it's generally benign, but you may want to follow it up because of rare cases like this. Here's another ant mini. This goes by a bunch of different names. We all know what this is. Tubular ectasia, dilatation of the rete testis, dilatation of the mediastinum testis, typically bilateral, often associated with epididymal cysts. They're completely benign. It's just dilated plumbing down by the mediastinum testis. Here's another one, long and transverse, and here's a normal mediastinum testis on this pretty 3D image. And a couple times a year, you'll see the form frus, the Latin, the different variations there. So this is dilatation of the rete testis, and sometimes it just looks bigger and weirder than normal. But again, this looks like tubules that are dilated. There's no soft tissue component. There's no vascularity. It's in the mediastinum testis. If you haven't seen one of these, they're kind of unusual. This is a silicone prosthesis, just like we use for breast augmentation there. This guy had a testicular cancer, so this is a cosmetic product there. So that's what it looks like. We had this earlier this summer. Remember that one of the biggest risk factors for testicular cancer is having had testicular cancer on the other side. So this guy unfortunately had metachronous testicular cancer, got bilateral prostheses there. Okay, let's move on to some other causes of scrotal masses. Bill Middleton has taught us that the best thing to see in testicular torsion is normal grayscale, abnormal color Doppler, like we have here. These are the ones we can untwist and get better. Dr. Prando wrote a really nice article years ago from South America saying, if you're in an area that isn't as lucky with healthcare, a lot of these patients will have their torsion, have horrible pain, will gut it out, and then will show up in your clinic 3 days, 5 days later. And you might say, oh my gosh, is that a testicular seminoma? No, it's the testicular tumor, the testicular torsion that's just twisted and risen to the top of the scrotal sac like that, and it's swollen, and so it's a tumor mimic. And here's an example of this whirlpool sign, just showing that twisted spermatic cord. So look for this. You don't see it very often, but they're kind of pretty when you see them. It's the best sign for a torsion. And one of my buddies who's a urologist sent this to me from the OR, just showing the correlate with the last 3 slides we saw. So here are 2 older cases of mistorsions. Enlarged hypoechoic, enlarged hypoechoic. You might confuse it with a seminoma, but when you get the classic history, you know what it is. And these are obviously avascular. This kid came in just 11 hours after he got hit in the groin playing hoops here. Here's the normal testicle for comparison. I was kind of curious, so I went to the OR. This testicle was totally black. It was dead. So in general, the literature says if you can untwist a testicle within 8, 10, 12 hours, somewhere in there, you can save it. Over that time, you end up doing an orchiectomy. Here's another one from this summer, so lots of blood flow around it. I think none of us are going to confuse this with a seminoma. This is just infarction ischemia in a testicle. Here's another one. You can see the normal testicle for comparison, edema, ischemia. The other point that this slide makes is don't trust isolated capsular flow. The lawyers love to focus on this. Make sure your techs get you a sample from the center of the testicle or somewhere close to the center where you get a nice tracing there, because obviously this testicle's dead, but it still has preserved capsular flow. There are other things that, besides torsion, that can give you infarcts. Used to work with this lovely, lovely surgeon who was great at hernia repairs. He really tightened down the inguinal ring so that the bowel and the properitoneal fat didn't go down there, but he kind of overdid it a bunch of the time. This is a known complication of hernia repair. So you tighten down so much that you prevent the hernias from going, but you kill the testicular artery. So I've got like 10 cases courtesy of him. This was billed to us as microlithiasis and a testicular tumor, and good for the outside docs. Lesions in the testicle are malignant till proven otherwise. But with the history there, this was just an infarct in the center of the testicle following hernia repair. Here's another one. Look at how big our sample gate is right there. No blood flow. This is a testicular infarct following hernia repair. Epididymitis, here's something I got from the web. Remember, you have the head, body, and tail, globus major, corpus, globus minor, 3D image. They can present as a scrotal mass. Here's the normal normal epididymis. The abnormal epididymis is enlarged and heterogeneous and all that kind of stuff. The clinical history is so good here, it's never a diagnostic dilemma. Here's a mass in the epididymis, a different patient, mass, testicular epididymis. But the beauty of ultrasound is both of these patients had a history of fever, white counts, STD, all that stuff. So urology was comfortable just giving them antibiotics and following these, and we watched these go away. Epididymitis is not benign, complications in up to 40%. Remember that we often have a concomitant orchitis, so here's the hyperemia that we see here. I'll always remember this case. This is another one of my many misses. This was a lovely kid with Down syndrome who couldn't really communicate with us. We did a great job first day looking at his testicle and epididymi. They were completely normal. 3 days later, he came back, and then I did what I should have done the first time, is scanned his entire scrotal sac. And this is back where the scrotal sac is attaching to the perineum. Put a needle in there, and frank pus came out. So learn from my mistakes. Look at not only the testicle and the epididymi, but look at the whole scrotal sac. This is an abscess, complication of epididymitis. Young males have testosterone poisoning, as one of my friends says, and they don't like to take antibiotics or follow rules. So normal scrotal ultrasound 12 days before, didn't take his antibiotics, shows up 2 weeks later with an abscess. I've got a million cases like this. This was billed to us as a testicular tumor, again, good for the outside docs, but we got this history of not taking antibiotics, suggested an infarct, so we went to the OR, they bivalved this, scooped it out, and that saved him a radical orchiectomy. Another case, the resident wasn't sure what was going on when she was scanning. She thought this was inside the testicle, but it turned out it was just a huge, gnarly scrotal abscess that was pushing into the testicle and partial volume averaging, looking intratesticular, didn't take his antibiotics. This is a great case. I've only seen one of these. Guy comes in totally asymptomatic other than this mass, ugly mass in the scrotum involving the testicle, the epididymis. We couldn't figure out where one started and the other one stopped right there. This was tuberculous epididymal orchitis following BCG therapy. So remember the immune modulation that we give for bladder cancer. We give them BCG, which is a form of TB, and that helps with the bladder cancer there. This has been reported to show up 10 years after their immune therapy there. It's kind of like Pott's disease in the spine. It's a cold abscess. This wasn't hyperemic. He didn't have pain there. So just keep that in the back of your mind, tuberculous epididymal orchitis following BCG therapy. Scrotal trauma, this was also from Sports Illustrated here. The main thing here, 2 points. Number one, your urologists are going to go to the OR if there's any question of disruption of the tunica albuginea. So really look at the tunica albuginea, and if you think it's disrupted, they're going to go to the OR for a bunch of good reasons to help the patient. Number two, as we've already seen, make sure there's no tumor underlying it. Again, obvious mass. All my injuries are following basketball games here, but this is how we diagnosed his mixed germ cell tumor following trauma in a hoops game. We get a lot of interesting Western injuries. This was a 78-year-old guy who was out riding his horse, got kicked by the stupid horse, laid on the ground for 3 days in Wyoming, was so tough in the wintertime, survived and came in. This is not a testicular tumor. This is just a hematoma from the sports injury. This was at the other opposite end of the spectrum, and a yuppie from back east who came out to Park City skiing, skied into a tree, the tree won. So you can see the disruption of the tunica albuginea. The key point here is if they don't go to the OR, and they almost always go to the OR, but if they don't, we have to follow these hematomas to make sure they go away, because these could be a seminoma that ruptured there. And these hematomas may take months to go away. They're not gonna go away just in a couple days. This is a hematoma, disruption of the tunica albuginea, hematocele. This was interesting. This was just from last week. I had to put it in. This guy got on the wrong end of a shotgun loaded with birdshot. Fortunately, he was far enough away, so you can see the birdshot floating around and multiple intratesticular hematomas there. This is another hematoma, not a tumor. He was explored. Here's the clot sitting in there. And then, great case. My friend Cynthia was doing her fellowship down at UCSD. This guy comes in with this linear thing in his testicle, and she's like, what the heck is this? She's a smart gal, so she gets a plain film there. And if any of you went to the chest section yesterday, we were talking about kinetic ballistic injuries. Long story short, this guy was in a drug deal gone bad 3 months before. He was shot in the testicle, but it was a handgun, so it was a low velocity projectile. He was wearing a leather coat, so that slowed down the bullet even more there. And there was so much adrenaline going on with the dispute and all that. So keep this in mind in your differential. If somebody comes in and says, Doc, I've had testicular pain for 3 months, he might have been shot in the testicles and didn't know it. Really, really rare case. I got shown this once on a film panel and had no clue. You know, you think, are these calcifications? Well, there's no shadowing. They're not punctate. This is a classic example of testicular lipomatosis and Cowden's disease, also known as multiple hamartoma syndrome. This is a really rare, but if you see one of these, it's truly an ant mini. These are just fat deposits in the testicles. Okay, briefly through extra-testicular things. The classic extra-testicular lesion is the adenomatoid tumor. These are benign. In general, most extra-testicular lesions are benign unless you're at a place like Harvard where you get weird referrals from all over the world there. So here are 2 examples of adenomatoid tumors. A third are hypoechoic, a third are iso, a third are hyper. These are benign, but again, humans being what we are, urologists and the patients get, kind of nervous, so we tend to get path proof on these, but the value we add is we say this is benign so they get an enucleation, not a radical orchiectomy. Here's what one of these looks like at path. Totally bizarre things can occur. This was an inflammatory pseudotumor. There's no way you're expected to figure that out. We have 5 embryologic organs that can give us appendices, the most common of which is the testicle, followed by the epididymis. I like this guy because he looks like a little duck. Here's one coming off the epididymis, looks like Bugs Bunny. They have blood flow in them. This is the etiology of the classic blue dot sign in the pediatric population. When these torse, they hurt, but we don't care. They just form little calcifications. Their only clinical significance is that we may confuse them with a testicular torsion. But if we know that it's an appendiceal torsion, we just give them Motrin. And it's the #1 cause for these so-called scrotal pearls or boulders. These things, the patients palpate them, they perseverate on them, so just put your finger on it, prove what it is, we're done. You can see Mike did a nice job here and actually labeled the images. Patient palpates the lump, and that's a scrotal pearl or boulder. Phil was at USC, at the county hospital at LA. They saw some amazing stuff out there. He called this the mother of all pearls here. Look at this lamellated thing just rolling around inside the scrotum. We're very politically correct in academia, so we can't call people prisoners, so our texts call these a guest of the state, or this gentleman comes to us from a gated community. This is one of the only examples of polyorchidism I've ever seen. When we wrote this up, there's no increased incidence of tumors or anything else right there. Here's another one that I thought, wow, I've got a second case of polyorchidism. Notice that we have 2 testicles over here. sweeping through, and then something that kind of looks like a third testicle. But this is the exception to the rule that most extra-testicular things are benign. This turned out to be a spindle cell lipomatous neoplasm. So weird stuff does occur outside of the testicles. Here's another case where I was 100% sure that we had polyorchidism with a mixed germ cell tumor in the third testicle. You can see two testicles right here, look totally happy, and then what looks like a mixed germ cell tumor there. We got the MR, and on T1 and T2, it was nearly iso-intense to the other two testicles, but when we gave GAD, it didn't enhance at all, and this turned out to be a pseudotesticle or an epidermal inclusion cyst in the scrotal wall. And once you see one of them, you start seeing them again and again. Varicoceles, we've all seen these, they augment. The only association with infertility is big varicoceles. Having said that, we do a lot for the tiny ones there. So augment, you can get reversal of flow, pretty 3D images. Clinical significance here besides infertility is, remember, the testicles started in the upper abdomen and migrated caudally. So if you have a mass of any type, a lymphoma, a sarcoma, a renal cell, they can pick it off. Varicoceles, 85% are on the left side because you have the double right angle there of the left testicular vein. So particularly if you see a varicocele on the right side, which is a straight shot, take a quick look up there and make sure there's nothing bad. Here's a left-sided varicocele, and we found a renal cell carcinoma. That's how we diagnosed it. This is one of our surgeons with a left-sided varicocele that he noticed when operating a long time. We go up to the left kidney, hydronephrosis. Look at this mat of nodes surrounding the aorta right here. I biopsied him 2 days later. He did well. This is lymphoma. This was referred to us as intratesticular seminoma here, and again, good for the outside docs being paranoid. But if you look at the grayscale, you can actually see flow here. So this is a rare entity of an intratesticular varicocele. The pressure just keeps going back downstream into the testicle there. Hernias, listen to Mike Williamson or Cindy talk about them. I think Marilyn's going to talk, but ultrasound's great. Most of them are just fat, but occasionally you can have bowel like you see in this Netter diagram here. Resident thought this was a sarcoma, couldn't see the testicle, but the poor testicle was just mushed at the bottom of the testicle, of the scrotum there. Have them Valsalva, things move back and forth, pretty easy to diagnose. Fluid collections we're really good at picking up. We generally have a history. This was a hematoma after hernia surgery. This is a post-infectious hydrocele there. And then the last thing we'll talk about is testicular microlithiasis. Fortunately, the literature has converged in the last 20 years, so I think we finally have an answer after all the contention. This is the most florid case I've ever seen. We actually got a radiograph of it. This one, remember, classic is 5 or more on one image, so these are obvious. This guy was the #1 plaintiff's attorney in town, made his life suing doctors, so the urologist went ballistic on this one. They ordered every tumor marker known to man and got an MR. And I just wanted to show, remember, high-frequency ultrasound is much better resolution than MR for picking up tiny little calcifications like that. Another classic case. Still 5 or more on one image, you're going to call it. In our paper, we rarely found focal lesions. Most of the time, they're kind of diffuse. So why is it important? We and others said there's an association with testicular tumor, but remember, correlation does not prove causation. There was another PEDS paper just in the last couple of years that came to the same conclusion. What we should do now is binary decision tree. If you see microlithiasis in a mass, you're done. The mass trumps everything. So here are 2 or 3 cases of big masses associated with microlithiasis. That's an easy decision because you're going to treat the mass right there. What should you do if you see microlithiasis and no mass? Take a look at this paper we wrote with Uro-Oncology and Bill Middleton and AJR. You may want to just take this blurb and put it into your PowerScribe. But basically you say, are you low risk? In which case we're done. If you have microlithiasis but you're low risk, you just do monthly self-exam like everybody else does. If you're high risk, you had testicular tumor, your dad or your brother had a testicular tumor, cryptorchidism, Klinefelters, yada, 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 then you're gonna go ahead and get plugged into Uro-Oncology just to get into the system there. So this is what we talked about right here. Let's move on to Sam's. This is what the residents say when I talk too much right there, like that little dude. Love this varicocele. We'll have questions in the other sections, but this is just perfect introduction for questions there. And then look at this little heart. This just shows the acoustic energy from ultrasound transmission in a hydrocele there.